And I will address fire accordingly. But come on in, please grab a donut and a coffee. There's donut and coffee, ladies. Please eat as many as you can possibly eat because I don't need them.
Sounds like your kids.
No,
Yeah.
no, not at all. Not at all. All right. Well, we're waiting. We'll give it another minute. Everybody in the room, I want you guys, we'll do this for fun. This is just shits and grins. Okay? This is not neurosurgery. This is learn this at Hogwarts here. Okay. Everybody think of a number between 1 and 10. Hold it in your mind, but don't tell me. Okay. All right. Everybody got the number between 1 and 10 in your head? Okay. You got it? You got it? Got it? Got it? Okay. Multiply that number by 9. Okay. All right. Everybody got that number? Don't? Yeah. Okay. Finger trick. Everybody got the number in their head? Should be a 2-digit number. Okay. Take the 2 digits of that number, add those numbers together. Okay. All right. That should give you a number. Everybody hold that number in your head. Don't say it. Okay. Now I want everybody to subtract 5 away from that number. Okay. That should give you a 1-digit number. Okay. Don't say it out loud. Now I want you to convert that number to a letter. Okay. So if A is 1, B is 2, C is 3, D is 4, E is 5, F is 6. Okay. Everybody got the letter? I want you to quickly, now don't get crazy like geography master. Okay. I want you to think of a commonly known country that starts with that letter, maybe in Europe or Asia, something real fast. Everybody got it? Everybody think of a country that starts with that letter?
Mm-hmm.
Okay, she's tracking. Okay. I want you to think of the last letter in that country's name. Okay. What's the last letter in that country's name? Got it? Everybody got it?
Mm-hmm.
Everybody got it? Okay, I want you to think of a common animal that starts with that letter. Got it in your head?
Yep.
Okay. Now that animal, the last letter in the animal's name. Think of a color that starts with that letter. Okay, everybody got it real quick? You got it real quick?
Yep.
Okay. Now I want you to think of a common American fruit. It's the last question. Common American fruit that's that color. Okay,
Perfect. Yeah.
everybody got it?
Can I see the last letter of that too?
Were you thinking of a kangaroo in Denmark eating an orange?
Yes.
Yeah.
Fine.
Awesome. Okay, all right, everybody. All right. We can do one more. We can do one more. Or we can go. All right, so good morning, everybody. My name is Brennan. So I'm going to give a little bit of a talk on neurosurgery, and then we're going to go to the back and try to learn some things. I'll try to fly through this. I actually combined 2 lectures. So this is critical care for the non-neurosurgeon. The first lecture I put together, and then the second one is a lecture I did on bullets and brains and why it's a love-hate relationship and a few facts that'll blow your mind. So then we already did this. Oh, here, we'll do another one real fast. Pick a number between 1 and 10. Okay, I want you to tell me a number. She's already picked her number. Tell me a number between 1 and 10.
2.
Okay, so I'm gonna get her. I don't know her number, but I'm gonna get her to guess your number 2. Okay, so pick a number between 1 and 10.
Okay.
I have 2 lectures today, so multiply by 2. Okay. And then I want you to multiply that number by 5. Okay, it's okay. Do your calculator. That's okay. This is fine. Okay. Soft. It's like your number.
Yeah.
And I want you to divide by the original number. I'm not looking. I'm not looking.
Okay.
Okay. Now hold that calculator up so I can't see it. Okay. All right. So what was your guess? Your magic number was 2, and I need to get you to 2. So I want you to subtract. She's thinking the number 8. So give me 8. Take 8 off.
Is that right?
Subtract 8. What do you get?
You just 2 person.
Yeah.
Nice.
That's what I had.
All
Wow.
right. All right. So anyway, we'll skip this one. This was the first one. You learn that at
Do you learn that in your, do you learn those
Hogwarts.
jokes? Oh, okay. I thought maybe you learned them in.
All right.
like,
So anyway,
fellowship.
background. I'm Ryan Brennan. Thank you for having me. I'm the neurosurgeon full-time Blessing. We have a couple part-time partners, but unfortunately, for better or for worse, y'all are stuck with me. So wear a helmet. I grew up in Indiana, in Warsaw. It's a town very similar to Quincy. So if you replace the QND or the Q on the fields with a W, that's Warsaw basically. I went to IU, graduated class of 2005. Jumped out of airplanes, got to blow stuff up, competed in Ranger Challenge, all kinds of fun stuff. Then I went to Indiana Med School, and then from there to a place called the Cleveland Clinic for residency, and from there to Harvard, and from Harvard to Blessing. I was lucky that in 2009 got to marry the love of my life. Oh, the sound effects are still there. That's from this is from the grand rounds I gave at Harvard. Sorry. Let's just enjoy this for a second.
Stimulating our
Don't ruin this moment, okay?
neurosurgery. Our neuro.
Please don't ruin this moment. Okay. So after we finished all like my residency and all that stuff, we moved out to the Northwest. We lived in Gig Harbor, Washington. We lived just over this bridge. Actually, if you drive over this bridge, there's a neighborhood right there, and that's where I lived. And then we sat at the foot of Mount Rainier, which is right outside Seattle. It's an absolutely gorgeous place. And I was chief of neurosurgery at Madigan Army Medical Center. This is what my backyard looked like. It's famous for this bridge called Galloping Gertie, which actually they built it in like 1939 in the summer. And then they didn't account for these side things catching wind. And so the wind across the Puget Sound is like the wind everywhere here in Illinois. You're all like wind. Anyway, along the Puget Sound, it's like a core, it's like a breezeway. And so this thing collapsed like 2 months after it opened. So it was a big deal. And in fact, I lived this is the bridge. I lived like right here. And it was kind of cool. I'm back in a little neighborhood. And as I said, I was at Fort Lewis, which is a special operations base. There's the 1st Special Forces Group, the 160th Special Operations Aviation Reconnaissance, and then a Ranger Battalion, and then us medical folks doing everything, a couple swans late. As I said, I got to marry my beautiful wife, Susie, and she gave me 3 beautiful kids. My daughter, Caroline.
No.
This is my son, Jack, and then my little guy. Actually, Jack used to wear this Black Panther costume all the time. And this is when he was like 4. He's a bigger boy now. He looks more like this. But he would wear this, and I realized that our Google cameras, I set not to recognize animals, didn't pick them up. And I was like, because of these little ears, and he was small. So it wouldn't go off if he was in the front yard, and I was upset because I couldn't tell if a kid was on the, on the street or whatever. So I was like, Jack, the cameras don't pick you up. And he was like, it's because of my Black Panther skill, Daddy. I was like, all right. But yeah, all right, let's do it. And then my little guy, Will, he's my troublemaker. So this is Will, and Will is now 4. This is him. This is like last Christmas. And then Will is my guy who gets in trouble a lot. So this is him at Christmas. I came down and it was too quiet. And where are you? As you'll learn, when things get really quiet, you need to go investigate. Okay. So I was like, Will, what's happening, brother? And
It's like, but that's so good. No.
it's like, gotta get one more swat. Get a swig in before we go. All right. So critical care for the non-neurosurgeon. Okay. So what we're going to talk about are some basic things like what makes ICP, what normal ranges are, and how they get affected. So the pathophysiology and management. Cerebral blood flow. Okay. So the brain, believe it or not, is the most important organ in the body. I know that the general surgeons want to say it's the appendix, and the orthopedic surgeons want to say it's the leg bone, and the dermatologist wants to say it's the wallet, but it is the brain, in fact. And so it's 2% of our body weight, but it's 18% of our cardiac output. Okay. And it consumes just a ton of our circulating oxygen. So when we talk about normal blood flows to the brain, cerebral blood flow volume of 50 to 100 milliliters per 100 grams per minute is normal, right? So when you get 0 to 10, what is that called? Membrane failure is what, when we think of code stroke. Thank you. All right, let's go stroke. But then there's this area, this kind of middle ground, right? And this is where it's synaptic failure, but not membrane failure. And that's the area that when we say time is brain, what we're trying to say, right? It's these folks. These people, unfortunately, they're just, the damage is done, can't do anything. But these people, these are the folks we're trying to save, okay? Activated.
He's coding right now, just for you.
Nailed it. Yeah, that's awesome. Couldn't have done better. All right. Yeah, love it. All right. So anyway, anybody know what this area is called? This is the part time is brain that we're trying to say. What is that called? The ischemic? There's a word starts with a P. Penumbra. Oh, sorry, it doesn't show up because of the penumbra.
Oh.
Right. So ischemic penumbra is like the watershed area. Basically, it's like the tomato plant on your backyard. It's a little under cared for. But if we get it some fluids and we get it some TLC, it'll come back and give us, some in the future, some good outcomes. So basically what this is saying is that to get any kind of measurement of cerebral blood flow, you got to be invasive, right? In most cases, you got to to infer cerebral perfusion pressure, you got to take MAPs and ICPs, and there's really no way other than, for the most part, invasive ways to infer this. Now MAPs, yes, of course you can sort of figure it out, but ICPs, you got to stick something in their head, which is sort of unfortunate, right? So when we look at this, what's interesting is over a very large, if you look on this is cerebral blood flow, and this is the mean arterial pressure. And all I want you to get from this is that when we have really low mean arterial pressures and low blood flow, we get passive collapse, which causes what type of stroke? Passive collapse. So the blood vessels don't pop open because there's not enough blood flow. It causes an ischemic stroke. And when we get all the way up here, when somebody's microdosing their methamphetamines, okay, what is this? Oh, I just take a dose, just a little dose, doc. What is it? Say it again. Hemorrhagic stroke. I love it. She's tracking. All right. So this is when the vessels break through, right? But what's incredible is over this incredibly large range in the map from 50, roughly 45-ish to like 50, 150, you have a very stable range of blood flow, right? It's well perfused with cerebral blood flow. And this is auto-regulation. This is critical, right? This is what allows us to Valsalva and do squats and cage fight and break dance and uppercut punks and give birth to babies and all kinds of things without dying and having strokes, okay? But this is critical because if we lose this auto-regulatory capabilities, we can start to have strokes. So when we talk about strokes, as we digress a little bit, we look at MRIs, right? So we've all talked about this, and let's check on learning for anybody who's ever had the unfortunate pleasure of calling me at like 3 a.m. They're like, I'm tired, but you want to tell me about MRIs? Oh my gosh. So I feel bad because they have to listen to my lectures on like MRIs at the bedside, but they're all very sweet. So these are 3 scans, 3 film sets from an MRI. Okay, this is the T2, this is the ADC, and this is the DWI. Anybody remember what DWI stands for?
Driving while intoxicated.
Very good. Yes, that too, but also diffusion weighted imaging. So in a diffusion scan, all this is doing, this is a computer algorithm that is calculating the rate at which fluids diffuse into and out of the intracellular space. So how fast does the sodium potassium ion channel work? And so what happens is in things like strokes or abscesses, that process is impaired. And so you get restriction of the diffusion. So you'll call it DWI, restricted diffusion, or restriction on diffusion. Have you ever heard that saying thrown out? So what that means is the fluids aren't going back and forth and they show up bright by the computer algorithm. So that tells you where the abscess is or the stroke is or whatever it is. But we have to confirm that that's real. So we confirm the DWI with the ADC, which stands for apparent diffusion coefficient. And so the corresponding white part of the DWI should be dark on ADC, okay? If it's bright on DWI and bright on ADC and then bright on the T2, it's called a phenomenon called T2 shine through, which is just artifact. It's like a glare off the rearview mirror. That's all you got to think of it. So when you look for a stroke, you want to look at 3 things: the DWI, the ADC, and the T2 to go. It should go white, dark, dark, right? 2 darks and a white, okay? Like an Oreo cookie almost. All right, so how do you remember that, right? Because it's like, oh my gosh, that's a lot of stupid stuff that I don't actually care about. It's really easy. DWI, it should be white. W, because I'm dumb, so I dumb it down. All right, so it should be white on DWI, and then it should be dark on ADC, right? So DWI, easy to memorize, okay? All right, so what are the determinants of intracranial pressure? So we babies should be, less than 6. Kids should be somewhere between 7 and 15, and adults should be less than 20. If you forget everything I say about ICPs, the only number I want you to think of is 20. And I want you to imagine if you were to run out in your backyard, jump in your pool, and go to the bottom, and just sit down, okay? If your ICPs are over 20, by the time you need to take a breath, you're starting to have cellular damage, right? So that's why there's urgency to this. And that's why you'll see in my order sets when I say, call me if the ICPs are greater than 20 for 5 minutes that aren't like, they go up and come back down. If they go up and come back down, or call me at any point if they're over 30 for any length of time, okay? Because we need to act quickly to get these things resolved, either by position changes, and we're gonna go through all the steps that you guys as nursing crew can do to have a very significant impact in a very short period of time, okay? And hopefully most of it is refresher. But in the old days, back in the day, 1800s, Monroe Kelly doctrine came out. Basically, all it says is the obvious. The head is a fixed box. You got your head as a Tupperware container, your skull. Inside is a Jello mold, and that Jello mold is wrapped in wax paper. That's the dura. And inside the wax paper is the Jello mold wrapped in cellophane, which is the arachnoid. But there are 3 components of things that constitute the pressure in the head. So there's the brain, the blood, and the spinal fluid. And at any one point, we have about 150 cc's in our whole spinal system between the brain and the spine. And it gets continuously made throughout the day, over and over and over again, okay? So if we let's talk physics, okay? So if we have a contained volume, she gives me that cup, and I keep trying to pump stuff into that cup, what's going to happen to the pressure of the fluids in that cup? If I have a fixed volume and I continue to add materials, what happens? Volume to depth. So the pressure rises until the volume either expands. That's how explosions work, right? So, or at least pressure cooker bombs. What's that from? Anyway, sometime I'd give you a talk, it'd be fun. We can go, anybody, who was military here? Any of you guys know? Yeah. Do you have to do the course where you like walk and look at all the different ways they can like blow you up and explode, and like IEDs and your trigger points, pressure plates and all stuff? You guys should see that. It's awesome. You can turn anything.
Sounds awesome.
That
It
sounds
is.
awesome.
Well, it is awesome because you're walking and you're like, you think, oh man, I found it. And then you realize you look up, there's a shotgun flying that. You're like, oh gosh.
Like,
Yeah.
Sounds
All right.
just
So,
delightful.
it is. All right. So I think this is a great model. If we break down the components of the brain into these three parts, brain, blood, and CSF, it helps me sort of figure out a model for which I can sort of evaluate the causes of elevated intracranial pressure. So when we talk about the brain, there's things like space-occupying lesions. So tumors, abscesses, foreign bodies, or in this case, a depressed skull fracture. So instead of adding more volume to it, I'm restricting the size of the container. So by virtue of that, it makes the pressure go up. Is that you or me?
sorry, it's me.
Oh, I think you probably turn your light off too. So
Yeah,
you get that
sorry.
all I didn't think about that. I'm gonna burn my
Oh,
battery.
you didn't turn yours off either.
I didn't either. I
felt
was,
bad.
didn't read the memo. All right. So, so then you also have things like cerebral edema. We see that all the time. That's a lot of stuff that you guys see off the streets, right? So the trauma and the DAI. Who knows what DAI stands for? By the way, this is, sorry, you're awesome and you're nailing it, but feel free to talk, ask questions, make jokes, contribute to the fun. I don't care what, this is a safe space, okay? A tree of trust, okay? But you were crushing it. So what'd you say, sir? Diffuse axonal. I love it. Diffuse axonal injury. So what is diffuse axonal injury? So if you think of the brain and the neurons like spaghetti noodles, dry spaghetti noodles, and imagine if I had a stack of spaghetti noodles in my hand and I was running down the street and I tripped and fell and my hand rotated around the spaghetti noodles as I came to a sudden stop, what would happen? I would shear off. Some of those spaghetti noodles would break, right? So diffuse axonal injury comes with a sudden deceleration with a rotational component. And what you get is a shearing effect of those neurons. And so what'll happen is you'll get a CT scan on a young person, they'll have like little polka dot bleeds all over their brain, but they're just devastated, right? It's a really bad process, especially when this occurs in the brainstem. So remember this. Other things like stroke and hypoxemia and sinus thrombosis, those are all things that contribute to increased pressure in the head. When we talk about blood, any intracranial hemorrhage, so I should update this, it should say IPH for intraparenchymal, but because epidurals and subdurals are both intracranial technically, right? Of course, any bleed in the head is an intracranial hemorrhage. But then there's also the response to injury, so loss of autoregulation. I had a guy that was doing methamphetamine with, it was marijuana with embalming fluid in it. And he and his brother got in a fight. He threw him off the balcony. The guy smacked his head off the concrete, damaged his hypothalamus. He lost his autoregulatory capability. And that resulted in neurostorming, right? Who's seen a neurostorm patient before? Anybody seen a neurostorm patient? 1 minute they're like hypotensive, and then the next minute they're hypertensive tachycardic. They're rigid, they're shaking, they're trembling, their ICPs are sky high, they're posturing, and then all of a sudden they're like, and you're like, what the hell? And then there's hypoventilation. So let's walk through this, okay? Don't look at this real quick. So, all right. So everybody look over here, all right? So if I stop breathing, what happens to my carbon dioxide level? If I slow down, goes what? And if my carbon dioxide level goes up, what part of my body realizes that my carbon dioxide level is going on? There's an anatomical meter in our body somewhere. Does anybody know where it is? Huh? It's somewhere in this area. Hit me. Nope, not the brainstem. It's in the neck. It's an artery in the neck. It's a carotid artery. Okay, so in the carotid artery, there are two things. There's the carotid sinus and the carotid bulb. Okay, they're right at the bifurcation of the carotid where it goes internal and external. And the carotid sinus is responsible for determining carbon dioxide levels. And that's what gives the feedback loop to the brain and then back down via the vagal nerve to the heart to either increase heart rate or slow heart rate, right? So when I stop breathing, my CO2 level goes up, which means this tells my brain that what is not getting enough oxygen. My brain is not getting enough oxygen, right? So my brain tells my heart to speed up, contract harder, and it tells my body, my ascending, activating reticular system through my brainstem to force me to breathe. So if I'm high on narcotics, that signal to my lungs doesn't go all the way down because the ascending activator reticular system is blunted by a narcotics overdose. That's why narcotics addicts overdose. That's how they die, because they stop breathing and then they go into respiratory arrest. That's their mechanism of death. Sometimes hypotension, but usually it's from the respiratory arrest. So I don't breathe enough, and I get hypercarbic. Okay, so my CO2 goes up, my heart rate starts going, and as a result, if I have a head injury, my heart rate goes up, my cardiac output goes up. What happens to the pressure in my head? Because what goes up to my head? What's being sent to my head?
CO2.
Blood. blood is being sent to my head to replace the CO2 with fresh oxygen. So the more blood in my head, the pressure goes up, and all of a sudden we're in trouble, right? So the problem gets worse. So I've had a head injury, and my body trying to fix the problem makes the problem worse. All right. And then there's also causes like cerebral spinal fluid. So obstructive hydrocephalus versus communicating hydrocephalus versus external. Do anybody know the difference between the three? I will tell you. Okay. So it's exciting. Obstructive is when there's blood in the way, like the shower. Think of it like the shower drain's clogged. Okay. Communicating hydrocephalus is when the drain works, but when it goes all the way up, out, and over the surface of the brain, CSF gets made in the center of the head, in the ventricles. It works its way from the lateral ventricles to the third, through the cerebral aqueduct to the fourth, and out the bottom of the brainstem, and then it goes around the spine and all the way up and over the head, over the surface of the brain, and gets reabsorbed into the venous system, into the superior sagittal sinus and the transverse sinus via arachnoid granules, okay, and venules, so that it basically osmotically pulled in. But what happens if somebody's had a brain infection or if they've had cancer, then that fluid doesn't get reabsorbed as fast. And so over time, it's like the drain works, but not efficiently. And so it slowly backs up the system over time. And those are the people that present with like, a chronic appearing dilation. They're not acutely sick. They're not dying in front of you, but they have obviously signs of hydrocephalus. External hydrocephalus is somebody who's either had a surgery and had a manipulation of the tissues or had a penetrating injury, like a gun, a knife, a sword, an axe, a hatchet, and you name it. I'll show you pictures of one of those later. And then there's of course intracerebral cysts. So how do we diagnose elevated pressure, right? So physical exam. So obviously if somebody's altered and they're doing something focal on exam, they have like hemiplegia, right? Half the body isn't working. They got a droopy face. They got one eye looking at you, one looking at your mama. That sort of thing. You're like, okay, that's not normal, right? But what if they have fixed and dilated pupils? Who knows the difference between mydriasis and meiosis? Which one is fixed and dilated, which is constricted?
Dilated is mid-driasis because there's a D in it.
Yes, somebody's picking up what I'm putting down. What's up? I know. I love it. You're sipping that sake from sake. All right, so yes, that's a D. So it's dilation. Okay. All right. So mydriasis is the medical term for dilation. And then there's the dreading Cushing's triad, of course. And so Cushing's triad is hypertension, bradycardia, and the respiratory irregularity. Anybody in the room know what the most common respiratory irregularity is in traumatic brain injury? Yes.
Good job,
Nailing it.
Casey.
You're on my quiz bowl team. All right. So Cheyne-Stokes. Who knows what Cheyne-Stokes looks like? Anybody? So it's a crescendo, decrescendo, followed by apnea. So you see them going like this. It's that guppy breathing. Sometimes people call it gupping, but really what it is, Cheyne-Stokes. So they go like this. They go, and it's progressively bigger, guppy, and then all of a sudden a big gasp, inhale, and pause. So it's like. And when you see that, it's a bad sign. If you see that, you should be calling me anyway, because the pressure in the head is really high. And so in that case, if you identify that as a good clinician at the bedside, you are running to the bedside to do all the things I'm going to teach you how to do to try to get your part of the job done while you're calling me into the bedside to fix a problem with an EBD or cracking the skull or something. So CT scans can show you a risk of high ICP, but the key here is that no study has ever shown a CT sort of algorithm evaluation of this or that or the other thing that confirms what an ICP is. You have to have an invasive monitor to know an actual number, but you can infer based on the findings. Obviously, if somebody has a massive bleed in their head, you can make a guess, probably accurately, that the pressure is high. So who do you think about putting a monitor in? So basically, if you're old, if you have blood pressure less than 90, a decorticate or decerebrate posturing on exam. All right, let's do it again. What is decorticate posturing? Sedona. What's decorticate posturing? Is it flexion or extension? Anybody know? Open tree trust.
Said Sedona.
Yes, you guys are so much smarter. So easy, if you ever forget, there's a lot of E's in the letter decerebrate, or the word decerebrate, which stands for extension. I'm done. So decorticate, pull towards your core, and decerebrate, you extend out, right? So what is worse, decorticate or decerebrate? What is the sign of progressive neurology? What happened first? Decorticate, right? So if we think about the brainstem, as the brainstem gets pressured down through the foramen magnum, there's a nucleus called the red nucleus. The red nucleus is in the midbrain, okay? And it is responsible for our flexor tone, right? So the upper arms do this, and the feet, if you ever see a patient, even if they're decorticate, the feet will always point, because the feet always have unopposed extensor tone. from a different nucleus, which I'll ask you to ask in a second, but they do this. And when basically the cerebral effects get taken out of the picture, the red nucleus takes over and it goes, uh-oh, so start doing this. And this is a bad sign. And they start yawning and they're doing their chain stokes and their eyes are getting wide. And then as the brainstem gets further compressed and the damage goes below the red nucleus is taken out, and all of a sudden it's all unopposed extensor posture. So then they start doing this. Okay? They start yawning. People are like, oh my gosh, he's tired. No, he's not. So extensor posturing comes from the lateral vestibular nuclei. Okay, and those are the unopposed, those are what allow me to stand up without consciously thinking about straight leg, straight leg, straight leg, keep talk, straight leg, keep talk, make joke. Okay, so that's that. All right, so who do we want to monitor? So basically anybody with a GCS less than 8, we're going to put in with an abnormal brain scan any of these abnormal findings. And so obviously somebody with a big bleed or intraventricular hemorrhage, tumor, hydrocephalus. And so what are our options? So affectionately the Bolt, right? The ICP monitor, communal monitor. So it's a waveform that's picked up through the fiber optic cable, which goes through this little bolt, which is why we call it a bolt, and screws into the skull, and the fiber optic cable goes into the brain parenchyma. And I want to show you on there how you know if this thing is in. See that little red dot right there? If you see that red dot right there, actually where my red dot is, but you see there's like a thickened larger casing here. Okay. So if that red dot is up here, you know that that thing is pulled out of the brain. Okay. So that's one easy way to know. And I'll show you on the Camino where it should sit so that you can, as a nurse, look at the bedside and go, yep, that's probably hasn't moved or adjusted, right? So this is good because this tells me what? It tells me my ICPs, but is it therapeutic or diagnostic?
Diagnostic.
It's only diagnostic, right? I can see the number and I can give medicines. And then, but I can't do anything like an EVD drain off fluid. What is the number we're shooting for? Less than 20. All right, so this is what a bolt looks like in situ, right? Of course. So this is before we put on the Curtilex. I usually put like a big Curtilex rapid, like a unicorn horn, but it's like a lazy unicorn. It's usually off to the side. But anyway, this is what it looks like. So you can see here, and you can see here that dot is sitting right inside there, right? And then we just kind of reinforce it so that it doesn't want to pull out, and then put a betadine soak something around that to protect it. The other option is an external ventricular device. And so you guys have all seen that. And the idea is that we take a catheter through the brain parenchyma and get it into the fluid-filled space. So we use an cranial access kit, which you guys will see in a little bit. You can go either from the back, which is Fraser points. Everybody feel the nubbin on the back of their head? Got no hair, so it's easy to see. So you go 6 up and then 3 to 4 over to the side. And you want to go over to the side. Of course, you don't want to go through the middle because what's the big, huge vein right there? Superior sagittal. Yes, superior sagittal sinus. If I put something through that, it'll kill them. So that's not good. So we want to go off to the side, and then we are aiming for the lateral ventricle, and our anterior landmark is the medial canthus on the opposite side. So I pass it from here, aiming here, and it should go right at the ventricle. The other option is Coker's point. Now this picture has a lot of things wrong with it. Number one is I make my incision anterior posterior, so if I ever had to make a cranial incision, it would follow along lines. So I make my incision anterior posterior. Also, this hand technique is abysmal. What you do, you hold it like a pencil. You guys have seen me do it. We've been in ED or in the ICU doing it. But you pass the catheter, and the idea is the catheter goes through and into the ventricle, and it sits right at the foramen of Monroe. Then I would tunnel it backwards 5 centimeters, and then out of the skin. Then I would make a retaining loop on the skin, and I would suture it in place. But so this is the idea. So here are your landmarks. So from above, this is the view I have when I'm standing in the room. So I want to mark my midline because that's my danger zone. So right underneath this, they didn't know what this sinus or this suture is called. Follows the sagittal suture, right? So right, and then what are these called? Coronal sutures. Very good. So I want the sagittal suture right underneath that is the superior sagittal sinus. So that's a great landmark. So if I follow from the middle of the eyebrows, right between the eyebrows is called the glabella. Okay. A little bit lower where the nose bone and the front and your forehead bone come together is called the nasion. You can feel your nasion if you just go like that. You feel kind of where those two bones come up. So if you measure from the nasion, you want to go 11 to 12 centimeters back and then 2 to 3 off the midline, but as long as you're in the mid-pupillary line. And if you go from the glabella, you go 10 centimeters and then off 2 to 3. And then I'll teach you how to do the tilt and the swag is what I call it to sort of measure it. But basically you draw a line to the medial canthus and then one to the tragus. And your idea is that these two lines are one's coming from the medial canthus, right? And one's coming from the tragus. And my goal is to get the tip of my catheter to come down and hit where those 2 points meet in space. And that's the foramen of Monroe every time. All right, so why not monitor everybody? Well, there's contraindications. Some people can get bleeds in their brain. Some people can have infections in their brain. And so it's not always safe, right? So there's a lot of things that we can do to manage pressures in the head. So if there's tumors and lesions, you want to call neurosurgery, but if there's edema, you want to get the water out. Sorry, it affects lost control. So mannitol, right? Mannitol is an osmotic diuretic. You give for kids 0.5 gram per kilogram, and for adults it's 1 gram per kilogram. And the idea is to get the pressure to come down by pulling fluid off the brain. Then hypertonic saline. And so the data sort of goes back and forth on how you do that, and we can sort of get the nuances of that at the bedside. But the goal sodium is somewhere about 145 to 155. And then, of course, there's surgery, decompressive craniectomies. If it's blood, of course, if it's subdural, epidural, and intracranial, you want to take it out surgically. And if there's reactive hyperemia, then this is where you guys come in and the life-saving stuff. So if a patient comes in and they have high ICPs, what are the things that you can do right away? So number one, elevate the head of the bed, 30 to 45 degrees, right? So if you have a patient, like we often do here in this area of the country, who are heavy set, bigger, so they're gonna have big bellies. And if you sit them up, all of a sudden too high, that pressure on their belly does what? It goes up. So if that does what to their intrathoracic pressure? Drives it up. And then when that goes up, what does it make it harder for blood to do to the heart? It makes it harder to get back to the heart, which then by virtue causes congestion in the head and elevated pressures in the head. So if I sit them to 30 to 45 degrees, that's sort of like, that's like the optimal location, because then they're like this, but they're not smashing down like this. The other thing you can do is you can actually put the legs in a dependent position, and that'll get you 2 or 3 points. If you're like trying urgently, just put them in a chair position. You'll get a cup, yes, you'll get some venous stasis, and maybe they get a DVT, but right now their brain is dying. So go for it, and we'll figure out the rest later. Okay. You also put an NG tube in or a Foley catheter tube in, right? So a Foley catheter decompresses the bladder, which decompresses intra-abdominal pressure, which therefore translates to lower intrathoracic pressure, which allows more drainage. Same thing. You take out the contents of the stomach. Number one, they're not going to vomit and aspirate when they are inevitably going to start puking. But also, you're taking the fluid out of the belly. That decompresses belly pressure, chest pressure, and then brain drainage improves, right? You also want to normalize the oxygen and carbon dioxide levels. We talked about that whole physiology of making sure that they're normal tensive, and that they're normal carbic, whatever the word is, normal CO2 level. So if you need to put a rebreather on or bag mask them, or if they're intubated, call respiratory and increase the respiratory ventilation for an end tidal of 25 to 30. Okay. Now, hyperventilating is a great technique that allows us to get a diagnosis quickly and intervene somehow. If I continuously hyperventilate you and your carbon dioxide level is real high, and I have that penumbra that we talked about where it's sort of at risk, that tomato plant's going to fry in the sun, right? Because if I leave you hyperventilating, that means I'm decreasing the blood flow to the head, because my brain thinks, hey, that hyperventilation means that CO2 level is really low. I don't need to keep pushing blood to my brain, so it drops it a little bit. And as a result, I don't get the brain blood flow. So that little area that's sort of on the edge of dying or living, it tips over the scale to dying if you do it for more than about a half hour. So hyperventilation works for about 30 minutes or less is my general range, goal range. It gives me enough time to get a CT, get back up, get an EBV, that sort of thing, okay? And then, of course, you can do things like sedation, like propofol and fentanyl and all that sort of stuff. CSF, you can divert the fluids. So just call me and we'll do the EVDs and we'll talk about that. Diamox is another option. It's a carbonic anhydrase inhibitor, and so it decreases the pH inside the fluid. So here are your emergency maneuvers. So stepwise approach, hemodynamic stabilization, ABCDs. Are they neurologically stable? Yes. Then rush down and get a scan, figure out why their neurologic exam sucks. Okay. Are they not neurologically stable? Then start doing these things that we just talked about. So elevate the head of the bed, nothing around the neck. Okay. A new patient comes in off the streets, the overzealous brain of EMS team intubated. They were so excited. They're high-fiving each other, and then they've got the ET2 bridles like this, right? Don't let the patient be turned to one side. A portion of the population only has one jugular vein or a diminished jugular vein on one side. So when they turn like this, if this is their one good one, maybe they had radiation on the side, or maybe they had surgery or trauma, or they knife fight or something like that, right? So they turn their head like this and they pinch off their one good jugular vein, and you do this, and all of a sudden their pressure is normalized, right? Because they've been used to living like that. Maintain the normal oxygen, get the CO2 down, and as we talked about, hypertonics for mannitol, things like that. All right, so a couple cases. So 23-year-old motorcycle versus tree, 90 miles an hour. So what do you guys see? Is this a CT or an MRI? Open floor. Anybody can answer the questions. Correct. It's a CT. So it's a CT non-contrast. So what is important? A CT, do we talk about densities or intensities? Densities. It's easy to remember MRI, intensity. CT scan is density. How dense is the tissue? How much does it block the radiation? So bone shows up bright because it reflects a lot of the radiation back. So it shows up bright. The soft tissues of the muscle block some, but not all, right? The brain blocks some, but not all, and it certainly blocks more than the fluid spaces, and definitely blocks more than the wide open air around the patient's head, which doesn't block any radiation, so that's why it shows up black, right? Does that make sense? So water does less than brain, that does less than bone. But what is this stuff? You see this stuff? Close. That's it's on the differential. But we have in this vignette a 23-year-old hitting a tree at 90 miles an hour. They also neurologically, their extensor posturing, they look absolutely abysmal. They look devastated, even though the scan doesn't look bad. And we talked about diffuse axonal injury, right? So these little petechial pintate bleeds all around the brain. You might see them in the brainstem or in the lobar spaces, whatever it is. This is diffuse axonal injury, okay? So it's a rotational shearing of the brain. So what do? Obviously called neuro, correct coagulopathies, hypertonics, blood pressure control, head of bed position, mannitol, the things we just talked about, okay? Diffuse axonal injury. So what's this right here? Is it CT or an MRI? CT. If you know the answer, say it confidently. If you're wrong, say it confidently. It's no big deal because this is a tree of trust. You can't be wrong, all right? But the more we know, the better we'll do for our patients, right? So what is this, CT or MRI?
CT.
Love it. When we know that because the bone shows up hard, right? But what do you notice about this parenchyma over here?
Got no flow.
What is it? Is it hyperdense, hypodense, or isodense? So relative to the normal healthy tissue over here. Hypodense, right? It's lower density, so more radiation passes through it. What is that a sign of? Close. Try. It's a lack of what? Ischemic stroke. Sorry, I didn't mean to hit with the laser. So, but yes, this is an old goat that fell down with an embolic stroke. Okay, so she had a right MCA infarct. So this is a very large right-sided stroke, the whole hemisphere. So her prognosis is pretty bad. Okay, same thing. So then sometimes patients say, well, for the swelling for this, because what happens is when the brain tissue dies over the course of 3 or 4 days, those cells that the sodium potassium ion channels on the cell wall that regulate fluid inside the cell and outside the cell, they die. And so the fluid gets stuck inside the cell, can't get out. And so all of a sudden the tissue, the components inside of that start to break down and the tissue start to swell. And so as the cells swell cumulatively in the millions of cells in there, they start to develop a mass effect and you get shifting of the brain. Okay. And so the question always comes up, well, why don't we just do steroids? Well, steroids in this particular case are responsive, right? Because it's caused by a failure of the sodium potassium pump. It's water and electrolytes stuck inside. The edema is intracellular and the blood-brain barrier is intact. So steroids are intended to help reconstitute the blood-brain barrier, right? They bring down the inflammatory cascade that wants to break that water seal apart. So it doesn't make a difference because that's not disrupted in a stroke, as opposed to a patient who comes in like this, where they have a metastatic disease, a metastatic lesion. You see all this edema around here. This is reactive and inflammatory, and it's caused by the vasoactive agents that a tumor secretes to try to basically get a foothold in the brain. All of a sudden, fluids leak out. So you give them steroids, and the blood-brain barrier reconstitutes, the swelling goes down, and so that edema is positively affected by that. Okay? As opposed to this one, this is the last one here. So this it might be a little hard to see with the bad lighting, but this is transependymal edema. See how this is? The ventricles are dilated and enlarged, and then you see these the fluid on the outside. Can you kill the lights for a second?
Yeah.
Sorry, everybody take a nap. I don't care if you nap. It's totally fine. You get paid to take a nap if you want. It won't bother me. But do you see how the ventricles are dilated, but there's fluid outside the ventricles? This is acute obstructive hydrocephalus, and you can see it on the MRI, the intensity out there versus the hypodensity here on the CT scan. What you see is the difference is these ventricles, this is a sign that this rapidly occurred and we need to intervene really quick or this person's going to die. Sometimes you see huge ventricles, but there's none of this stuff. And that just means this chronic old man brain, something like this shrunken over time. So here's some examples. So what is this picture right here? What is this? What does this look like? So this is a CT. So there's 3 CTs and an MRI. Here's the MRI. Okay. So the CT scan shows an axial cut CT non-contrast. And what do you notice about these dark spaces? What are these? What is this? Anybody know what this is? Is this the brain is fully formed, or is it shrunken or atrophied or anything like that?
Atrophied.
Yeah, so this is old man brain, right? So you see the enlargement of the sylvian fissure and dilation of the ventricles, but notice there's no transpendable flow. And then over here, you see the fluid spaces. All the brain is smushed up against the wall. There's no atrophy of the tissues. The fluid is enlarged, but there's pressure going out. And the reason why this happens is the pressure gets so high that the ependymal cells lining the water-filled sac in the brain, the ventricles, they stretch out and it pushes the fluid into the tissue of the brain. Like it's soaking, like a piece of wood sitting in water eventually starts to soak up water, right? Does that make sense? All right, this is a fun thing. So that's old man brain. This is acute obstructive hydrocephalus. This is an emergency. This is called open lip schizencephaly. So this is external CSF where there's an opening in the brain, but it's lined by gray tissue. So that's schizencephaly. And then this is encephalomalacia after a stroke. Okay. All right. So here's an example. Microdosing is methamphetamines. Okay. So what do you see here? Anybody? CT, MR? Okay. And what's the finding on this scan? And what's the finding on this scan? What is finding right here? What shows up bright on a CT scan? You said it. Shane, you said it.
Blood.
Oh, you said it. Okay, blood. So this is acute blood from a hemorrhage in the cerebellum, and that blood has pushed over into the ventricle. Notice what his pressures are. So what is the etiology of this bleed? Hypertension. He was doing his methamphetamine or his cocaine, right? They bled here, pushed into the fourth ventricle, which blocked the flow of the lateral ventricles, and so you have acute obstructive hydrocephalus. Okay, this is an emergency. We need to get a ventricular right away. Okay. All right, so Decadron won't help. You get neurosurgery. In your case, sit them up, head of bed, normalize, make sure the neck is free, breathe them down. If you know a patient's going downhill and you want to draw a set of labs, I will never be upset if you draw a set of labs and send them right then and there. Coags. So if you ever have the inclination that I might need to call Dr. Brennan at the bedside emergency to do a procedure, and you send a set of a CBC, a BMP, a typing screen, and a set of coags, for the rest of the time, I will always say, awesome job. I will never care, okay? Because I would rather you be proactive and think of that, and then tell me you did it afterwards, and I will say, good for you, than us have to go, oh my gosh, we need to do this, but let's figure out if this guy's hypercoagulated, hypercoagulated. Just, it's fine with me. If you guys ever are at the bedside and you're like, should I get a CT scan on this patient? And you feel like you should, go for it. Just call me if you don't know, and if you feel like, hey, there's an emergency, tell the ICU doctor we need a CT scan, take them down. I will never be upset. Okay. All right. All right. So a couple more. So 29-year-old doing some cocaines. Okay. On the weekend shows up with this finding. Anybody know what this is? CT. CT. Very good. And what are we looking at? What's the pattern of this stuff? This white stuff. What is that called? What is that white stuff in there? Is it edema or is it blood? What shows up bright on CT? So why does blood show up with fresh blood? Why does it show up bright on CT scan? So when blood comes out, what shape does it make? It's a donut shaped, right? But instead of the hole in the middle, it's a biconcave disc. So when that blood cell is floating around, okay, and all of a sudden it goes out of a blood vessel and it's sitting still, it's a little hard object. There's hemoglobin in it. And that hemoglobin is a dense enough molecule that when the radiation hits it, it bounces back, so it shows up bright. But as the blood stays out of the blood cell and it doesn't refresh with fresh oxygen, the blood cell dies, it starts to break down. So that's how we look at a scan and we can tell if it's fresh blood, subacute, or chronic blood, because as the blood breaks down, the radiation passes through it more easily. So that tells us that, I'll show you some examples of that. So this is acute blood, and this is what we affectionately call a dead chicken sign, okay? And that's an aneurysmal rupture around the basal cisterns of the brain. So this is an aneurysm rupture, okay? As opposed to, so an aneurysm is when, like, obviously, like a blood vessel bursts, and that's bad. So the difference between these, so this is traumatic, right? And this sort of looks at versus aneurysmal. And this I call like a beignet, all right? Everybody knows what beignet is? All right, so it's like a beignet. It's like powdered sugar dusted over the surface. Whereas this is a dead chicken sign, all right? Now you see it? And now you can't unsee it, right? So that's the dead chicken sign for the little feet and then the arms and the wings. So, all right, so aneurysm outcomes, basically they're bad. Most people, like 1/3 of people who get one die and they don't make it to the hospital. Basically, the biggest risk is rebleeding after you've had a first rupture. And the initial cause of death, the most common immediate cause of death is a recurrent bleed. Okay, the long term is aneurysm, is a vasospasm. Risk factors for aneurysm: if you're a woman, polycystic kidney, if you're pregnant, hypertensive, on birth control, you do substances, tobacco, cocaine, chronic alcohol, methamphetamines, that sort of stuff, whippets, uppets, all that stuff. Increased risk of rupture during lumbar punctures, advancing age, and prior aneurysms. So there's a whole way to measure these. Hunt test is how bad your symptoms are. Fisher is how much blood there is. And then there's a whole management strategy. So we'll get into this, and then I'm going to skip through because we got plenty of time. You're stuck with me. I'm sorry. So in the management of ICP, so aneurysm subarachnoid, right? We're going to get an EVD in, and because I don't do endovascular, I didn't want to get radiated for my whole life. We're going to send that out to Springfield. But we might have to manage the neurocritical care for a short period of time, and we're going to do a great job. So we want to use propofol for our sedation. What's the advantage of propofol over things like Versed or Ativan or things like that? Why do we use short acting? Exactly. But also propofol has the added effect of all benzodiazepines or GABA stimulating agents of lowering ICP. Okay. Additionally, why would we choose specifically in the aneurysmal patient? Why would we choose fentanyl over morphine? What is different between fentanyl and morphine? One is nature made and one is synthetic, right? So in a morphine, the biggest risk after a patient has a rupture of an aneurysm, the immediate risk of death is a recurrent bleed until it gets coiled. Once the aneurysm is clipped or coiled, the big risk of death in the next 25 days is vasospasm, where the blood outside of the vessels stimulates the other blood vessels to contract down like a muscle spasm, and then you get a stroke. Synthetic narcotics like fentanyl will not initiate or trigger an allergic reaction like a morphine can, right? Or a Dilaudid can. And so when you give morphine or Dilaudid in these patients, there is a finite, very small, but in some people who are allergic to that, you can initiate a histaminergic release, a histamine cascade that causes an allergic reaction and potentiates the chances for vasospasm and kills that ischemic penumbra. Oh, full circle. All right. So other things, obviously head of bed for our management. I'll skip through the stuff we're not getting to. You want to reverse anticoagulation. So the ICU should be doing that. So you guys should be drawing blood coags. Ask the doctor for nimodipine, right? Nimodipine is good. It's been shown in the long term, if initiated, to decrease the risk of, improve the outcomes neurologically. In the old days, we used to give statins, but it isn't really borne out that it actually makes a difference. So you don't really need to do that. You want to give a hemoglobin goal of 10 to 30, right? To optimize blood volume and viscosity. So if they're hyper, don't worry about it if they're too high, just give them some fluids, right? Don't volume deplete these patients. And in most patients who've had an aneurysm rupture, you probably want to get an echo, send cardiac enzymes. So this should be part of your lab panels thinking, hey doc, should I send cardiac enzymes? Because when an aneurysm ruptures, you get a catecholamine surge and that can blunt and stun the heart. So sometimes patients go to the hospital as a heart attack when they've actually ruptured an aneurysm and they're on the cath table. They run a catheter in, shoot the heart, and they're like, oh, this is normal. And then they get a CT because the person's like not following commands. They get a CT and there's a big aneurysm rupture. All right. So don't fluid restrict, treat with hypertonics, give fluids. If you have an aneurysm patient and they don't have a central line or an art line, ask the doctor for one right away. Just get it right away. Just say, hey, these are the things that you're thinking, because we're all in this together, right? Like if I score the goal, you score the goal. If you score the goal, I score the goal. We're all one team, one dream. So if you see this stuff, tell me, right? So here's aneurysm. This you see right here, vasospasm, where the blood vessels clinch down, and this is after it's been treated. Okay, vasospasm right here, where it's been clinched down, and this is after treatment where it's been dilated again. So mechanism of action, right? So it causes irritation. You can look for it with Lindegard ratios, but we don't have that capability here. It's not a big deal. Traumatic subarachnoids, they don't vasospasm. Almost by and large, they don't really do that. Notice the difference. It looks like powdered sugar over the surface of the brain. ICPs, so aneurysm, blood pressure less than 140. If you can get them, if they're young and healthy, less than 120. If it's traumatic, less than 160. So you always see my recommendation is 90 to 160, head of at 30 degrees, keep 1 hour neurochecks, etc. Reverse the anticoagulations. If their ICP sucks, then we'll do an EVD. What's GCS? GCS, everybody knows what GCS is, right? Glasgow Coma Scale. What's the best score you can get? 50. Right? So what is the best you can get on motor? Eat one. Have another one, please. As many as you can, please. Everybody get another donut. All right. 6 on motor, right? If you can't remember that easily, there's a V6 in your motor, right? V6 engine, right? How about eyes? What's the best you can get on your eyes? 4, right? If you don't remember that, if I wear glasses, 4 eyes, right? What's the best score you can get? 5. V, Roman numeral V for 5. Okay, easy for verbal, right? It's too easy, right? You gotta dumb it down. So these are various subdural hemorrhages. So here's the difference of what I was trying to talk about. This is a CT scan. So do we talk about densities or intensities? Density. So it's this hyperdent. This is the blood right here on the right side of the brain. And what do you notice about the midline? It's being shifted over to the left. So this is a 2 centimeter, roughly, my guess, 1.5 to 2 centimeter bleed with approximately 1.5 to 2 centimeters of right to left midline shift. So you see that septum pellucidum should be in the middle between these two things, right? So this is acute, and it's acute blood, so it blocks radiation, so it shows up bright. But as the blood ages, you see this right here. Here's the bleed on this side, right over here. But notice that it's isodense to the brain tissue. This is a subacute bleed, okay? So acute subdural, subacute bleed, and then what is this over here? Is this hyper, hypo, or iso? Hypo. Say it loud. Yeah, I love it. Hypodense. So that's a chronic subdural hemorrhage. So management, this is superstat to the OR. This is, you could observe if they're like horrendously ill and don't want surgery, but you're probably taking them to the OR to take this out. And then this patient, you could watch, observe, or you could even do endovascular coiling of a middle bronchial artery. Here's an example of acute on chronic blood. And you see a fluid level where the blood is layered out here because they're laying. Why does it layer out like that? Gravity, because they're laying in a CT scanner, right? So they're laying back, so they get the fluid level down here, and this is the chronic blood. So this is acute on chronic blood. This needs surgery. Okay. Here is another example. Don't be absolutely convinced that this is chronic blood. If you have like Jehovah's Witness patients or somebody who's chronically anemia renal failure patient, sometimes this can be acute blood, but they're so anemic. Like if their hemoglobin is like in the 5s and 6s, that can actually be acute blood. It's just not dense enough to show up right. Here's bilateral. This is a coronal view, so face on, and you see the collections here and here. And so you would open this up, make an opening in the skull. So here's some incisions. Again, I don't do this way. I always go this way so that if I ever had to extend into this bigger opening, it's a little more cosmetic. But in the OR, I'd lay the patient on the side. I'd prep this side of the wound. And if I were doing it, I always do a mini crania. I don't really ever do burr holes because sometimes you can't see inside when you do a burr hole and you can set off bleeding. So my incisions go anterior, posterior, right? And the mid, basically right here. It goes here and here on the side. Then I take the bone flap off. I call it a Coke bottle crania. So it's about as big as your coffee or maybe your drink, maybe your Stanley or your cup. Anyway, so then it allows me to look up and look back and I can wash all the fluid out. So you go through, you open up the dura like this, you make an incision, open it up, and then you irrigate out the blood until the fluid that comes out, you could read a newspaper through. Then you start to close it up, and put a drain in, and then I send them to you and you guys nail it and take good care of them. So example of somebody we would do that too. This is an acute bleed. This needs the big hole, the dome popped off. You need to do the big trauma flap, big question mark, pull it off, lift the whole bone out, and take the big clot out, save their life. It's pretty awesome. So big wide cranie. This one you could probably observe. So where do you guys see the blood? So this is a CT or an MRI? CT. Yep. So where do you guys see the blood? Is it on the right or the left? So here's the right, here's the left. Where's the blood? What? Yep, left. Do you agree this is the blood right here?
Yep.
Is it acute or chronic or subacute? Try again.
Acute.
Subacute would be isodense, the same color as the brain.
Acute.
So it's brighter than the brain, so it's
brighter.
acute, right? So here's the easy way to remember. 7 hours, or 0 to 7 hours is hyperacute. 7 hours to 7 days is acute. 7 days to 7 weeks, subacute. 7 weeks and beyond is chronic. Okay, 7, 7, 7, 7, 7. Okay. All right, so this is a big epidural. Okay, we got to take the epidural from the OR, get it taken out. So the difference between epidural is it respects the suture lines. This actually probably is a subdural. It's a little far back, or it's a little high. I can't tell. Anyway, it's a subdural or epidural, probably epidural. But the epidural is outside the dura. Obviously, subdural is under the dura. So an epidural, an epidural bleed will get stuck at the coronal suture because the suture lines are sticky points for the dura where it kind of sticks to it. And so they make that lenticular shape. So again, here's an epidural right here. And so epidurals need surgery. The only time you observe them really is if they're less than 30, less than a centimeter and a half, less than 5 millimeters of shift, no focal deficits, and GCS, pretty much normal. Here's a couple other examples. This is a person who has a ventricular catheter, either an EVD or a shunt, and they're being overdrained. So they're developing bilateral subdurals because the brain is shrinking in the middle and sagging away. And then here's an example of somebody with intracranial hypotension. So on the coronal MRI, you see the post-contrast enhancement of the dura all the way around, which isn't normal. And that's because the brain is sagging, you get venous congestion. All right. So here's a good one. All right. If you guys are getting bored, just put your hand up. What is this? Anybody know? What do you see here on the X-ray? And what do you see right here?
Not good.
What doesn't attenuate radiation? This stuff.
Air.
So what is this right here?
We have air.
So what is it called when you have air in your brain under tension? Tension. Tension pneumocephalus. This is actually called the Mount Fuji sign after the Mount Fuji in Japan. All right. So what is this right here? Anybody knows of this sign? Raccoon's eyes. What do you think the chances of this breaking up? I sit down.
I think you're okay.
I'm a big boy. All right. All right. So these are raccoon's eyes. Okay. So the patient comes in, say they have, and then what is this? When spinal fluid drips out of the nose, what's that called? CSF,
Leak.
odo,
Otorrhea.
out of the ear, and CSF out of the nose is
Rhinorrhea.
Rhinorrhea. Very good. So this is CSF rhinorrhea. Okay. So this is the poor man's test. We get a white cloth. The blood drips out of the nose. They get the blood that stops, and then the CSF keeps going. The real test we send is a fluid out of the nose, collect it, and send it for beta-2 transferrin. But for us, unfortunately, blessing, that's a send-out test, I believe. All right, so let's do an anatomy quiz for fun. Okay. Oh, so say a patient has this sign right here. All right. So don't put them on CPAP or BiPAP. Why? What if the doctor walks in, isn't thinking, and goes, "Hey, put that patient on a BiPAP." You see this, you go,
Brennan says no.
say no, and just if you see something, say something, right? If anybody ever yells at you for being safe, fuck, sorry. All right, but like I will crush their skull if they do that verbally, emotionally, but not physically. Let me take it back. Let's be professional. I will give them the business, okay? Because you guys are being safe. I want you to be safe, and if your actions are in the best interest of the patient, I will go to bat for you 100% every time. Okay, even if you're dead wrong, we'll figure it out and we'll correct it if we need to. But like, I would rather you be trying to be safe than just blindly go, oh, okay, I'll put that CPAP on and pump a ton of air into somebody's brain, right? So don't put anything. They say, hey, put the NG tube in. You're like, I don't think that's a good idea. Why? Because if I put an NG through a skull-base fracture, I can put it in the brain, right? And then I want to watch, I've got this injury. I got to watch for diabetes insipidus, make sure they're not dumping out tons of urine. Hey, doc, they put out 500 cc's in an hour or 350 in 2 consecutive hours. Should we send a sodium to make sure they're not in DI? All right. And they might say, hey, they're post-op, they're just diuresing, but okay, we'll send a sodium point of care test or send one down. Aggressive bowel regimen, you don't want them valsalvating and then reconstituting the leak every time it seals itself off. And then don't let them blow their nose, and then don't let them use straws or incentive spirometers. One time they won't use incentive spirometer is that they're sucking on that thing. It's like sucking on a milkshake or something. All right, so here's pop quiz. What's this called?
Battle sign.
Love it. Quiz bowl. All right, so battle sign. So if I had a fracture back here, how could I possibly get, this is high level thinking. How could I get a leak right here out of my nose? Spinal fluid, what's broken back here when I get hit and I've got that sign? The skull base is broken, right? And what part of the skull base? Anybody knows? There's some mastoid air cells, right? So tell me how I get CSF leak if I have this injured. Anybody? Walk me through the anatomy. There's a break of, okay, so there's a break of the mastoid air cells. Notice how these are pneumatized. Okay, and these are filled with fluid. That's the blood and the spinal fluid inside the air cells. These are the mastoid air cells on the right, and they're nice and full of air. There's skull fracture over here, and these are full of blood and water. See the difference in the color, black versus white? Because there's air there, it doesn't attenuate radiation, but over here, it's attenuating. So the fluid, you get a punch in the back of the ear, you hit with a bat, right? You break this. That fluid then goes from there into the middle ear, right? Because it breaks through these air cells, spills into the middle ear. They can't hear anything. And then it runs down what tube? The eustachian tube, which comes out in what part of the back of the mouth? The nasopharynx or oropharynx? Right here.
Yeah.
Right. So what is this little lip called? This is called the torus tubarius right here. This little lip over top of the opening of the eustachian tube. So the fluid drips down here. So the patients say, man, it tastes like metal in my mouth, or real salty, right? So that's why we always say you have salty metallic taste, because they're sitting up and it runs down, hits the back of their tongue, which is the bitter center. Right? If they lean forward, then it spills out of their nose and you arrive at this. So that's high level thinking. All right. So what is the diagnosis here? What's that sign? Raccoon size, right? Versus this, which is questionable life choices.
Yeah.
Right? All right. So no judgment if anybody does that.
It was the early 2000s. Give us a break. We all had our emo phase.
It's okay. Hey, no judgment. This is your journey and I'm here with you. Okay. I will support you. I mean, God, definitely not the pinnacle fashion. But what also is concerning about this picture? So this guy had, they thought the brand new ER nurse, whatever, was brand new excited, thought there was air in the stomach, where this is actually air under the what? What is this thing called? That's diaphragm. This is air in the stomach, which is bad. This is air in the intra-abdominal cavity. So they stuck this in, and then unfortunately, the patient becomes unresponsive with fixed and dilated pupils after suction was applied, right?
Is that the NG tube? No.
Yeah, that's the NG tube.
Nice.
Right, and so these are exhibits A and exhibit B, right? From the
Wow,
lawsuit.
I can't imagine.
Right, so here's so not good, right? Don't be that person, okay? We'll skip through this for the sake of time, but this is a pituitary apoplexy in a patient that has just had a baby. Like in labor, they get an ischemic thing to the pituitary gland. You're cool, you're good. Anyway, so they get visual deficits, which is called a bitemporal hemianopsia. It's really tragic because they'll never be able to see the Eiffel Tower again. And so that's just a joke. My wife the other day, she told me that we should embrace our mistakes. And I was like, I agree. And then she gave me a hug. I don't know why she did that. Anyways, we'll skip through this because I want to get through some other things. This is an intracranial hemorrhage on the left, which got taken out surgically and decompressed a broken vessel on the other side and gave a bleed on the other side. Okay. All right. So hypertension, real common. Have you ever seen like old folks, they get these big lobar hemorrhages? Why is that? So it's called amyloid angiopathy. Basically, think of it like the hose gets dry rot. So what happens, instead of these elastic, nice contractile tissues of the arteries that allow you to expand and contract, they become real stiff and rigid with this stuff called amyloid. And that amyloid on a pathology slide will come up yellow, green, birefringent, but it basically is like dry rot and then they burst. So that's why old folks all have these big bleeds in like the lobar regions of the brain instead of down in the putamen. Okay, strokes, the risk factors, we're gonna keep going. This is a stroke on the left side. So this is an MRI or CT. MRI. So this is the ADC, right? The apparent diffusion coefficient. Oh, sorry, this is the T2 as you were. Sorry, this is the T2. This is the DWI. So what should a stroke look like on DWI? Okay. And on the apparent diffusion, emphasis on the wrong syllable. Fastest. Sorry, what? Or should on ADC, where should it be? What should it look like in a stroke? Thanks. God, that was difficult. Sorry. And then it's normal on the T2. So there's a giant left-sided stroke. So give them, this person needs a copy of the good book. Tell them to start studying for the final. Because the left-sided stroke, most people are left brain dominant, right? So this is speech production and speech reception. So this is quite devastating. I would not, in most cases, offer surgery for somebody like this. This is an ACA infarct, and you just see on the DWI the whites, all right? And then this is an occipital stroke. So what would, in the occipital lobe, any know what part of the brain is responsible for what the occipital lobes do? Eyesight, very good. So vision. So if they had this side, this is the right side and left side. So right-sided stroke, where would they have a cut on the visual field, left or right? Left. So it's a left homonymous hemianopsia. So because it's behind the optic chiasm, it respects the vertical meridian, this halfway part, right? If the stroke is in front of the vertical or the optic chiasm, meaning in the optic nerve or the eyeball somewhere, you'll get little patches of blindness. But when it's behind that, you get a whole half of the brain. All right. Cool. All right, I'm going to skip through. These are infections. This is an empyema, so you see the infection. This is an infection. We're going to skip through this. This is a true story. I got called as an intern, a second year, to go see a lady with, this is off topic, so I'll go fast. But she had a lumbar abscess, and I went to go see why she was having the abscess. I pulled her foot back, and she had this really stinky big toe wrapped in gauze. She said it was getting amputated. The next day I was like, oh, okay. I said, well, are you diabetic? She said, no, I'm diabetic, but I got a new puppy.
Oh.
And I fell asleep on the couch, and I woke up when my dog chewed through my toe like a chew toy and got to the bone. And that's what woke her up. So the dog had used her toe like a rawhide. Anyway, all right. So here, I'm almost done. Go with me. Bear with me. This is great. Everybody having a great time? Best time ever, maybe? Yeah. All right. You guys, there's more coffee. There's a shit ton more coffee. Notice. All right. So this is a true story. So when I was at Madigan, I had a young, unfortunate gentleman making bad life choices out in the woods with his drug dealer. And his drug dealer got upset at the price he was willing to pay for his drugs. So his drug dealer pulled out a hatchet and attacked him. And he hit him once in the head. And then you see he went right through C2, through the spinous process of C2, and then a bunch of times through the skull. So if anybody's squeamish, just let me know. So you can see here, impressively lifted this off, did a craniotomy, right? In the most impressive way I've ever seen. He shaved the bone right off the superior sagittal sinus without lacerating the superior sagittal sinus. If this got cut, you bleed out in 15 seconds. It's like hitting the jugular or the carotid, okay? So he literally shaved it, but also look at this giant air gap from the tissue defect. He cut all the way to the inner table. Hang on. That's a big call. All right, so he cut to the inner cortex of C2, a millimeter thicker, a credit card thicker, and he would have gone through C2 at the spinal cord and killed the guy instantly, decapitated him effectively. So this is what it looked like. So he came in, so he decapitated him, and then you see the big gash. This is all hemostatic agent. So he rolled into the OR, and all of a sudden he started getting real hypertensive, but it didn't look like he was bleeding. Turns out he was laying on a backboard that they hadn't pulled him off. And anesthesia was taking their sweet time getting him intubated, and he was bleeding behind the backboard, so we couldn't see it. So we flipped him over emergently. I unsterilely just grabbed a bipolar and started going to town on the muscles to coagulate him, and then I stuffed this in, and then I just betadine prepped and draped him. And I prepared for this massive transfusion and blood loss through this because of this, and I lifted this up, and it was fine. I lifted the clot out, laid the bone back down, put two plates back down. Sorry, I put 2 plates back down, and then the next day, the guy was totally fine. He woke up, and I was like, I looked at him and I was like, do you understand how serious this was, soldier? He's like, I'm so sorry, sir. And I was like, you need to make better life choices. I will. And I'm like, do you have families? I have a daughter. And I was like, you need to do better. And I started yelling at him. And then Who knows? Hopefully they better. Anyway, good story. These are my beautiful children, so let's just change topic. All right, last one. So this is a Taliban soldier that I operated on. Oh, this isn't last. I've got a lot more. But we'll keep going. Am I doing on time? I'm over time. So we've got like an hour still.
Yeah.
Okay, so I need about 10 more minutes. I'll just fly through whatever. So when I was in Afghanistan, I was the director of trauma critical care for U.S. forces in Afghanistan and chief of neurosurgery for U.S. forces in Afghanistan. So it was kind of fun. I got to be in charge and sort of direct stuff, and you get to go like do meetings with CIA and stuff. It was really cool. I felt like a James Bond. I'm sure I'll tell you that story later. But so anyway, long story short, they called me one night and they were like, "Hey, we've got some people coming in." I said, "Okay." So they brought in, it was a mass casualty. There were enemy forces and U.S. forces. We took care of the coalition forces, and this guy came in like 30 minutes later. This is a young Taliban soldier who turned himself in. He knew he was going to get injured. He wasn't actually injured in this fight, but he saw this fight, saw the medevacs, came out of the woods. And what happened was this guy had been in a fight with our Rangers about a week before. He got blown up by a grenade from a distance, and it collapsed the orbit. And this was pushing down on his optic nerve in the eyeball. And he slunk off in the woods, got stitched up with baseball suture by a doctor without diplomas. And he was like leaking fluid and infected. So he came in and he was like, oh man, he couldn't see his eyeballs all like this. So we took him in, we brought him in, and we had to fix him. So we had to reconstruct the base of the skull. And so we did a bicoronal incision. So you see it here. We basically took his face and pulled it down over his eyes, and then went and reconstructed the front of the skull. And you can see here how it's all macerated. So we took all this bone out, reached in, took out all the mucosa, reconstructed the base of the skull, and we got it all nice and done here. And his vision went from like 2200 back to 2040. And so he woke up, and I was like, I gave this guy a lecture, because when you go in to see soldiers or the enemy, you're supposed to desensitize, just take all your like unit badges and your name stuff. I was like, whatever. So I walked in, the translator's behind the curtain. I looked at him and said, hey man, listen, I want you to look around. And there were nurses working, because he had like shrapnel and everything, his legs, we were working on that. I was like, listen, I want you to remember what we're doing for you here. I said, I know you think that we're different people, but we're not that different. And what we want is not that different. You want your family to be safe. I said, and that's what we're trying to create for you guys. I said, I want you to remember this, because one day you're going to get thrown in a prison, and then you're going to get thrown out 2 or 3 weeks later because they run out of space. And you're going to go somewhere, and somebody's going to give you a gun, and they're going to put you on top of a building or in a tree or off on a hill. And one of my brothers and sisters in arms is going to walk in front of you. And I want you to remember every person in this room trying to save your life right now. Because when that person crosses in your crosshairs, I want you to make a choice not to pull the trigger. Because when that guy decides not to pull the trigger, then that person goes home to their son or their daughter or their husband or their wife. And my goal when I went to Afghanistan, I realized like I'm one guy, I'm not going to win a war. It's ridiculous, right? Been there 20 years, what am I going to do? Well, I realized like my mission is my why are my wife and my children, right? That's the reason I get out of bed, the reason why I work hard, the reason why I tell dumb dad jokes, try to do this sort of stuff, is I want them to be proud of me, right? So if I can get one person's Susie or Jack or Caroline or Will to go home to them, right? Having served the flag instead of draped by one, then I would have done my mission. So this guy gave him the business, and I was like, don't pull the trigger. You know, your decisions make have impact, right? So it was my chance to have an impact on a bigger picture than just my own. And so it came together nice and pretty, and so we got him better. All right. Pick a number between 1 and 10. Did we do this one at the beginning?
Yeah.
All right, everybody in the room, I want you to think of a 2-digit number between 10 and 50. They have to be odd. The 2 digits have to be odd numbers, and they've got to not be the same number. So between 10 and 50, and both digits have to be odd numbers, and both digits have to be different.
Well, that doesn't leave very many.
Okay.
Fair.
Everybody thinking of one?
No.
You got one in your head? Are you thinking of 37? Yes, you. All right. All right. So I'm gonna go through this one real fast. Bullets and brains, because I've got about 10 minutes, then we got some practical stuff. Okay. Everybody want a donut? Anybody need to stretch their legs? Anybody want to stand up? Is anybody born out of their skull? I'll get out of this if we are. All right. So this was all right. So basically, gunshot wounds are really bad unless you're Carl. Okay. And so if they're really bad, most people die at the scene. Oh, what'd I do?
Shannon did it. She went to
No,
the call.
I did it. That's good. So bullets come and they form problems because not only does a bullet go through the skull, but it like cascades, it rolls and tips and pitches and it yaws. All right. So let's get physical, right? So what really matters at the point of impact is the point of impact, the speed at which the bullet hits the head, right? Or hits the body, right? That's what matters. So let's see if this is a 50 cal going through a watermelon. So this is an Afghan national police officer I took care of, got with an AK-47 through the skull, and you can see devastating impact to the skull and the calvarium, how that shatters everything. So I can tell you just by looking at this is high caliber, high velocity, high impact, right? As opposed to things like grenades, where these are low velocity injuries, okay? So when we talk about low muzzle velocity, right? So this is less than 250 meters per second, as opposed to large caliber weapons, which create a cone of death as they go through, okay? Not only does it have the impact velocity, but there's a shock wave that follows it that creates this, because the bullet is not that wide, but that's the cone of death, if you will, all right? So high muzzle velocity 600, they're uniformly fatal, okay? So basically, if the brain, so secondary injuries, you get cerebral abscesses, traumatic aneurysm, seizures, fragment migration, lead toxicity, obstructive hydrocephalus. So basically you're hosed if it's going through here, right? If it goes through the brainstem, you might do okay depending on the side here it goes through. This is a bad thing. This went in one side. So which side did this probably go in? Who said right? Hold up if you think it went in the right side, not the left. Who thinks it went in the left and not the right?
Well, are we, the right's on that side? Oh, yeah, I see that.
That's right side and left
Okay,
side.
so it's backwards. And it went in on the.
Yes, correct. So you
Right.
see, correct. And so these are recoil shatters. This is either debris or this is recoil shatter. And you see the big edema from the massive trauma to the muscle. So it's swollen. And then it goes through the bone, but then you see the outpouching of the bone here. And then you see bullet fragments here. And there's a bullet fragment there. Okay. And then everything's obviously exploded out. So obviously. All right. So general management, ABCs, ICP management. All right. So from a nursing standpoint, when you see a patient, the eyes are the window to the soul. Okay. So if you see, these are the most beautiful eyes in the whole world. Okay. All right. These are my wife's eyes.
Oh.
I'm sorry if your husbands have been lying to you all these years, but she in fact has the most beautiful eyes in the world. Just your husbands are trying to be nice men. Okay. Or your wives. All right. This is the veil of death on the eye. When you see this curtain, it's like the veil of death. Okay. This is, you're not coming back from this. If you see that glaze over the eye, that's it. Say good game, America. All right. So that's it. Okay. All right. So skulls. So we talked about the head of bed. We talked about all this. Let's go through a couple more pictures here. Some more fun pictures. All right. Here's the last one. So this is a guy actually that was in Afghanistan. He was a Charlie Guardian. So these are the Afghan Special Forces. So this guy got hit in the neck by blunt trauma from an IED. He fell, smashed his neck, and gave himself a stroke. And he got picked up by the French doctors who tried to do a craniectomy on him. It sort of cuts off a little bit, but you can see the craniectomy is from here to here. This is completely and wholly inadequate. It's like taking the top off a toothpaste tube and squeezing a decompressive hemicrania should go from here all the way back here. This whole thing should be gone. It should be the size of my hand, right? Like this. On a head as big as mine should be giant, right? Get dinner plate. Right? So this guy, unfortunately, even though they tried their best, he still was under pressure and he starts mushrooming brain out of this hole, right? And so these guys didn't have a drain for his brain. So they put I swear to God, a Neptune suction tube, poked holes in it under his bone flap. But the transport team, who was Polish, didn't know that was not to it. They connected that some gun to a wall sucker. And so all of first grade and all of, his first 20 years of life were sucked up in the first 3.5 feet of the tube when he got there. So there's nothing we could do. This is a wholly inadequate decompression, right? This is the CT. I pulled the drain out before he went in it. So you can see this was inadequate. They tried to take this little fragment out. But what do you notice about this down here? So this is the foramen magnum. And what is this structure right back here? The cerebellum. And what are these tonsils doing? They're squeezing out of the foramen magnum. That's herniation, right? It's herniation. Notice how you can't tell the difference between gray and white junction. You can't see the difference. High pressure, a sign of a high pressure is the loss of gray-white differentiation. And then, of course, you can see this area, which is the CT scan, right? So this CT scan, what is that showing me? Hypo or hyperdensity? Right here.
Hypo.
Hypodensity, right? Exactly. What is this showing me? Hypo or hyperdensity?
Oh.
No, this stuff, the dark stuff. Hypodense, right? Relative to the brain. So this is a giant stroke. And what is this hyperdense stuff right here? Nope, try again. It's not, here's the bone. You see the bone is real
Blood.
Blood. Exactly. It's blood. So that's fresh blood in the muscle and over the scalp. Along the falx cerebri, you see the midline is shifted, and then there's a big, huge stroke, right? So this he's in a bad way, right? So there's not much we're going to do. And so, all right. So this is just what a hemicrania looks like. So we position like this, big question mark shaped incision. This is, I like 3 slides left. All right. And then so we go through this. All right. And then so here's the injury, make a question mark. And first thing I do is mark the midline. So my patients come back with a big purple line in the middle of their head. I have a seizure while he's drawing. Anyway, so then I make a big opening And then I pull everything back, and then I open the bone, so I identify this, I make a bunch of holes, and then I'm gonna lift the bone flap off. Okay, and then I'm gonna lift the dura back, take all the clot out, see the brain underneath. And then if it's a decompressive hemicraniectomy, I'll leave the bone flap off and I'll stellate the dura like that. If it's a craniotomy means bone out and stays out. Craniotomy means bone comes out, goes back in. So know that's an important difference, right? That makes implications for you guys. If the patient has a craniectomy, there's no bone, so don't lay them on that side. Don't wake them up by going, "Hey sir, hey sir, wake up." All right. So that would be bad. So then if I put a drain, you'll see most of my patients will come back with a drain. And then if they don't have the bone, I'll do something to help you out, right? One team, one drain. All right. All right. You hit the lights for me. 3, 2, 1. Everybody last one. All right. I got one last one. Can I get anybody have a piece of paper?
Yeah, here.
I need a blank piece of paper. Okay. All right. Can I get a second piece of paper?
Yeah.
All right. Okay. All right. Here it is. Check this out. Okay. You got I need a pen as well. All right. I'm so needy. So needy. All right.